Okay, so I'll get started. So hello and welcome everyone to the BHF Data Science Centre monthly webinar. So I'm Sarah Lessos, I'm one of the research project managers at the centre, and this month's webinar is entitled Cardiovascular and Diabetes Call for Funding Awardees Mini Showcase. So earlier this year, we launched a call for funding to support studies on cardiovascular disease and/or diabetes and COVID-19 in collaboration with Diabetes UK and the BHF. So these projects have formed the first major steps as part of our diabetes data science catalyst, as well as supporting the ongoing research within the centre. So I'm pleased to be joined by two of our awardees. We've got Dr Anvesha Singh, Associate Professor in Cardiology at the University of Leicester, and Dr Stephen Kaptoge, Principal Research Associate at the University of Cambridge. So before we begin, can I just ask everyone to keep their camera and microphone switched off, and note that this webinar will be recorded and will be available afterwards on the HDR UK YouTube channel. And so we will have time at the end for discussion. So please post all of your questions in the Q&A, and we'll do our best to make sure that we answer all the questions that have been posted. And if you would like to present at any of our future webinars, please do get in touch with Kate McAllister, our Communication and Events Manager. So first of all, I'm just going to share a little bit about the webinar. So I'll share my own screen just now before I pass you on to our presenters. So we're going to hear from Anvesha about understanding the sociodemographic trends in treatment of aortic stenosis and the impact of COVID-19. And we're going to also hear from Stephen about the impact of COVID-19 on the association between type 2 diabetes and the incidence of cardiovascular diseases, with a focus on associations by age at diagnosis of diabetes. But first of all, I'll just run you through about the call for funding and the projects that we have funded. So it was a rapid funding call. So we launched this at the end of March and it closed at the beginning of May this year. The total funding that we had available was around about £500,000. And the funding call was open across all of the data science centre thematic areas. We had around about 120 to 150,000 ring fenced for the diabetes data science catalyst projects, and we expected to fund around 8 to 10 projects. So the priorities across this call for funding were research that was within the CVD COVID UK COVID impact infrastructure. So projects needed to have a COVID focus in addition to cardiovascular or diabetes. We wanted to look for research which aligned with some of the centre's thematic areas. Projects designed to have a positive impact on healthcare and/or reduce inequalities. Projects that could be delivered rapidly, and projects that were deliverable within the current data and that would utilise a wide range of the data sets available. We also wanted teams to demonstrate that the patient and public involvement and engagement is an integral part of their proposed work. Specifically for the diabetes data science catalyst, we wanted to look for research that will help build resource for the diabetes community, that research is at the intersection of cardiovascular disease and diabetes, and that would help to promote the work of the catalyst. So in total, we funded 13 projects, which is around about 500,000 as planned. 3 projects had existing consortium approval and now have been able to progress as a result of the funding. We had 3 projects that extend work currently being undertaken by consortium members, and 7 were brand new projects. And we also included 2 projects which are full service, which meant that the analysis would be delivered by the health data science team within the data science centre. And 2 of the projects sit within the diabetes data science catalyst. So just to give you a little bit of a flavour of the projects that are funded, I won't go through all the titles, bearing in mind the time, but we have projects across congenital heart disease, inequalities, risk and cardiovascular disease. We have 3 projects in that category. And we have 2 projects that sit under clinical trial planning and the effects of COVID-19. We have, as I mentioned, the diabetes and cardiovascular disease projects. We have 1 project which is looking at pregnant women with heart disease. We have rare disease versus common cardiovascular disease. And then we have 2 wider scope projects as well. one of which is the British burden of cardiovascular disease. So I'll just stop sharing there and I'll pass straight on to Dr Anvesha Singh to talk about the project that she's involved in.
Thank you, Sarah. I'll just share my screen. Okay, great. Thank you. So hopefully you can hear me okay. As Sarah mentioned, I was one of the recipients of one of these funds and actually one of the full service support. So I'm very grateful for that. And I'm going to just briefly describe my project background and go through some of our initial experience of working with the data science team. I'm not really going to present much data and results today, just to warn you. So the topic I'm looking at is aortic stenosis, and this is the commonest valve lesion requiring surgery in our country. And it's characterized by a very long and variable asymptomatic phase. It affects as many as 1 in 20 adults over the age of 65, but the exact number of people and characteristics of those people is not known. And what's unusual about it is that most people may develop this disease gradually and slowly, and therefore may not know about this until they get symptoms. But really severe symptomatic aortic stenosis is sort of the end stage of disease. And many people are often incidentally diagnosed by a heart scan called echocardiography. And this may be done either for a different indication or if somebody hears a murmur and requests a scan. Once people are diagnosed, they then remain under follow-up, usually in outpatient clinics with possibly annual echocardiograms and also monitoring for symptoms. And current guidelines recommend treatment only once people become symptomatic. And the only available treatment at present is to replace the valve, either through open heart surgery, known as surgical aortic valve replacement, or more recently, keyhole transcatheter aortic valve implantation, known as TAVI. So the question that we asked really was, is there equal access to treatment for this condition in England? And the reason for asking these questions were because some studies, particularly in America, have suggested that there are ethnic differences in access to treatment and who gets and when they get treatment, with ethnic minority groups are less likely to get both surgical aortic valve replacement and TAVI in America. We also know that socioeconomic status has an impact on most elective procedures as well as post-operative outcomes. And finally, studies have shown there are differences between men and women in terms of who gets what type of treatment and when, and some differences in outcomes as well, although this data is not conclusive. So this led us to ask the question if there are health inequalities in people being treated for this common condition. There is evidence, of course, to support that COVID has had an impact on health inequalities and possibly worsened health inequalities. And this is just one report published by the Midlands Decision Support Network looking at elective spells in England. And essentially, if you're at 0, there's no health inequality. If you're above 0 on the y-axis, there is greater health inequality in the less deprived areas. And as you can see that gradually over time, the health inequalities have increased and COVID seemed to have impacted it even worse. So when we're talking about people with aortic stenosis, of course, their patient's pathway is very long, as I mentioned, because of the variation in who presents and when. But really for this project, we're focusing at the end of this pathway when the people actually get referred for treatment and are given surgical or TAVI for their condition. So the main questions we wanted to ask was, what is the sociodemographic makeup of patients undergoing these 2 procedures in England? And what has been the impact of COVID on this? We wanted to use national data sets to try and address this question and capture as many of the procedures as we can. So we want to use NICOR data sets, which capture all surgical aortic valve replacement and TAVI, but we also wanted to utilize the opportunity with HDR UK to link these data sets to other important sources, such as HES, GDPR, and ONS data, to improve the completeness of data as they may be missing fields, but also to get more of a greater understanding of the outcomes of these people as well. So this project was originally referred as one of the CVD COVID UK consortium projects and already had approval at the time of applying for this funding. So just briefly, I'm going to talk about the progress so far since the funding was approved. So as already mentioned by Sarah, this was a very rapid call and the launch was only 31st of March. And I was informed that the full service support funding was given on the 19th of May, so very quick turnaround. The contract setup was also equally quick, and I had my first meeting with the data science team on the 22nd of June. So as mentioned, I was one of the ones to get the full service support, which meant that rather than getting a fixed amount of money to fund my own team, I'm working directly with the data science team who are analysing the data with me. So I'm working with Fiona and Anna, and those are just some of the dates of the meetings we've had so far. And in addition, we've also had a few email exchanges in between. And what we've done in this time is we've confirmed the aims of the study, we've confirmed the timelines that we want to look at, and a lot of time is focused on really defining the code lists. So specifically using ICD-10 codes for defining aortic stenosis and OPCS4 codes for both TAVI and SAVR. And of course, as you'll know, this is real world data, so the coding is never perfect. So we're trying to sort of come up with the best way to capture what we want to capture. Since then, we've also done some initial cohort exploration and data curation, and initial key patient characteristics have been explored. This is just one example of the sort of thing that we've discussed in the meetings. So for example, defining TAVI is not straightforward because there isn't a single code for this. So what we've chosen to do is look at these three codes, for example, K26, Y79, and Y53. And as I mentioned, not all the coding happens on the same day in a uniform way in the NHS. So we've decided to use a 4-week washout period where we've said if all three of these codes are present within the 4-week period, we count that as an event. If it isn't present, we move on to the next code. So that's just one example of the sort of ways to ensure that we try and capture as many of the procedures and the conditions as we can. And very briefly, so far, we've decided to look at the time period between 2000 to 2022. And this is because we also want to explore if there's been any changes in the trends in terms of the type of treatment, but also who gets that treatment. Overall, the number of people with the code of aortic stenosis is around 765,000. And the total number who've had a procedure in this time is around just under 200,000, with a mean age of 70 years and 63% being male. So I just thought it might be useful just to talk through a few teething issues that we had, because this is the first time either of us have worked in a project like this, and also mention some positives as well. So the initial issue I had was, as I'm not a data scientist, I don't have access directly to the TRE, which meant the initial meetings were difficult because you're not allowed to share the screen, so I couldn't quite see what Fiona or Anna could see. And there was also the transfer of the data from the TRE to SDE, which initially created some delays. And it turned out we were not allowed to export HTML documents any longer for security reasons. So in the end, Anna and Fiona came up with a compromise where they got an agreement to export reports as PDF files, which were first checked by NHS output checkers before being sent to me. And this has been working quite well since, and the first one was sent on the 1st of September. The other hurdle we came across is that we found out that the NICO audit data, unfortunately, is not provisioned from the beginning of its existence. And for SAVR, we only have access from 2013, and for TAVI from 2018. So what we've decided to do is really use the HES APC data as our kind of main data source, but we're going to look at the subgroup of the audit data as well. And this will allow exploration of how well the two sets link and what is the sort of match between the two. And we may also do a subgroup analysis with more detailed information from the audit. But really, overall, the positives have been the main sort of take home really for me. So clearly, because I'm a clinician, I don't have any experience in dealing with such large data sets. So having the expertise of the HDR UK team has been invaluable. We've also been able to leverage some of the experience, for example, code lists for comorbidities, etc., from other projects rather than starting everything from scratch. I've also found the plots of the initial exploration that I get sent on the PDFs quite useful because it helps me sort of further define questions and an analysis plan. And of course, the most important advantage, I think, of this whole process has been the speed. I'm sure anybody involved in research will know that's kind of the biggest limiting factor in getting data and getting results. And the speed of the actual grant itself, but also the speed at which the analysis is taking place has really been excellent. And I can't wait to share some results with you soon. Thank you very much for listening. I'll stop sharing.
Great, thank you, Anvesha. If I can ask anybody to put questions in the chat, and we'll come back to questions for both Stephen and Anvesha at the end. So Stephen, if I can pass on to you now.
Hey, hopefully you can hear me. So thanks for attending this meeting, and apologies for those of you who are consortium members who may have attended a previous session where we had presented some of these results, or rather plans. But I will explain more of what we want to do, because we've just recently submitted a protocol on this work. And just to mention also that we are doing this work in collaboration between colleagues in Cambridge and in Bristol. And no doubt we will borrow some other experiences from the people in the BHF Data Science Centre. So we come from the background that, of course, now it is very clear that people with diabetes have had more worse outcomes during the COVID-19 pandemic. And clearly from this national diabetes audit initial data, we can see that there is excess risk of mortality, first of all by type, and also that maybe the differences might be increasing by age. However, we also recognize that diabetes may not necessarily be seen as a binary condition, as in present or absent. So which motivated us to maybe think about what other characteristics of diabetes may be worth looking at in terms of the impact of COVID-19. And as part of that also, there have been the recent results from the CVD COVID UK consortium showing that, yes, the excess risk of cardiovascular conditions are initially very high, although they decrease, but maybe up to 1 year later, they're still higher, and especially in the people who are hospitalized with COVID-19 diagnosis. And given we know that people who had diabetes were more likely to be in the hospitalized group, then it also motivates us to think that maybe breaking down the hospitalized group into people with diabetes or not, and by age, may also be of interest when assessing the longer-term consequences of COVID-19 infection. And that comes from this background work, which we have done in a pre-pandemic period using data from the Emerging Risk Factors Collaboration, UK Biobank, and CPRD data sources. So here we were looking at what is the excess risk of mortality according to the age in which diabetes was diagnosed. So first of all, in CVD, which is all cardiovascular related conditions, fatal or non-fatal in the CPRD, and then specifically mortality when we were combining data from ARFC and UK Biobank. And here we can see that there is a very steep dose-response relationship, which is showing that, if you have diabetes diagnosed at a very early age, about 30, then, the excess risk for cardiovascular conditions is about 4-fold, and mortality is about 3-fold. With a clear difference between men and women in that excess risk. So it then becomes of interest as to how these might have been affected by COVID-19 pandemic. And then also when we looked at these in terms of translating these excess risks into a more interpretable measure, which is, for example, years of life lost, then we found out that there is marked differences, or rather important differences in the years of life lost according to age of diagnosis of diabetes. So here, and this is work which has just been recently published in the Lancet Diabetes Endocrinology. So we see that for people who develop diabetes at age 30, then life expectancy from age 40 compared to people who don't have diabetes at that concurrent age, if you're male, is almost a difference of 14 years. And then if you compare to people who develop diabetes at age 40, then that's almost 10 years. And then, so if you look at the average age of diagnosis, is usually around 50 to 60 years old. And that turns out to be the aggregate estimate of about 6-7 years, which have been found in previous studies. But actually, you can see the heterogeneity across the age of diagnosis is quite substantial. translating to about 3 to 4 years lower life expectancy, a decade earlier diagnosis, at least at the age of 50. And we think, first of all, these results would be useful, first of all, as an anchor for quantifying what is the impact of developing diabetes, and B, as an individual, you probably would be motivated to do something if you really looked at what might be the impact of developing diabetes. So clearly, the message here is it's better to delay diabetes onset to later ages in order to live longer. So the key question then is, okay, fine, we know that the COVID-19 came in and then it had more impact in people with diabetes, and then that translates to larger reductions in life expectancy. But then we don't know whether that might be also differential according to whether your age of diagnosis was younger or older and you had COVID-19. So our main aims is really to better understand, disaggregate the characteristics of diabetes and COVID-19 into more interpretable, or rather more clinically useful interpretable measures. So our specific aims in CCU 73 is to look at age of diagnosis, and particularly looking at interactions with COVID-19 diagnosis and taking into account vaccination status. And then instead of looking at mortality only, we now will be able to look at non-fatal events, and therefore be able to calculate what is the CVD-free life expectancy, as well as maybe the overall life expectancy. And then we will also look at, because we know there have been differential impact of other risk factors, including, say, ethnicity, deprivation, and we know the prevalence of diabetes and age of diagnosis may also vary according to these conditions. Then we would want to look at subgroup analysis according to these characteristics. And then in the longer term, we also hope that we could extend this work, at least if it becomes possible that we can do non-CVD related conditions. Then the whole point is to develop a pipeline of analysis which could be translated to other conditions. So the inclusion criteria is we will have 2 cohorts essentially, and the reason for that is we don't know whether it will be possible or feasible to handle the large data sets. And the second one is we probably would want to maybe start off with a cohort which have pre-existing COVID diagnosis. Therefore, the first start date is 2020, if we're able to update coverage in a time-dependent manner, or we start on 2022, which is the mid-pandemic, in which case we will have people with history of COVID diagnosed. And then we will include everybody in the primary care records and then living in England. And then to distinguish type 2, type 1 diabetes, we will either use the codes available, or if it's not immediately clear, then we will probably take a cutoff of 30 years to maybe focus on type 2 diabetes on the first instance. So at the moment, we've just populated ICD codes, and we will match with corresponding SNOMED codes, which we will take from previous projects. The specific cardiovascular conditions we have prioritized is CHD, dysrhythmias, which include atrial fibrillation, heart failure specifically, all stroke, and then peripheral vascular disease and deep vein thrombosis. And we've chosen to be more specific for those because we want to see what is the specific association between age of diagnosis and each of those outcomes. But also we will extend to a wider definition of cardiovascular mortality, which includes hypertensive disease and all other ICD codes, including sudden death and all other codes which may be associated with CVD. And then we will define non-CVD death as any death which is not in the CVD category. We will follow standard procedures, and we will, in this case, use survival analysis for specifically Cox regression to look at associations. And then we will specifically look at updating diabetes status and age of diagnosis as a time-dependent variable. If we start from 2020, or otherwise, if that's not feasible, then we will start with a time-fixed cohort at mid or the 1st of January 2022. And then just to give you an idea of what we mean in terms of public health sort of modeling. So we will look at multi-state transition models where we have 4 states. So initially we will look at people who are CVD-free in state 1, or they could have a non-fatal CVD, which is the non-fatal outcomes in that table I'd shown you. Or they could die from CVD, which is state 3, or they could die from non-CVD death. And we will use the data to inform the transition probabilities in an age-dependent manner, which will help us to derive survival curves and be able to calculate differences in life expectancy according to diabetes status. So in principle, the things we need is age-specific relative risks, which will be calculated by sex in each of the data available. And then we will also look at the prevalence of diabetes by age and sex and age of diagnosis. And then we will also need the incidence rates in the overall population for each of these transitions. And then on that basis, we could derive an incidence rate for people without diabetes at any particular age, and including now stratification by COVID-19. And that will give us a way to estimate the survival curves for comparing people with and without diabetes at a particular age. So for example, here, when we did the mortality analysis, we could look at the reference curve for people aged 30. What is the survival for people without diabetes, which is the orange curve? And then if you develop diabetes at age 30, given the relative risk estimated, what would have been your survival over the lifetime? And then the difference in the areas under those 2 curves gives you the differences in life expectancy, or the years of life lost due to diabetes. And you can see that the areas shrink as you develop diabetes at an older age. So essentially, that's the process we would want to repeat, but maybe now concentrating on non-fatal events as well as different types of fatalities. Because one thing we could do also is to break down the total, maybe now CVD-free life years, but here it was mortality. We could say, okay, among the total years of life lost, what was actually causes of death? And here we can see that majority of the causes of death were in vascular diseases, as well as non-vascular, non-cancer mortality. So we hope to also do similar thing with respect to survival free of CVD. So hopefully I'll come back to you with results in a couple of months. And I would just like to acknowledge the funding from the collaboration and PPI panel, who had very excellent comments in our proposal, and several people whom we have bounced ideas while navigating the process of working the theory. Thank you.
That's great. Thank you, Stephen and Anvesha. So I think we have a few questions pre-prepared for you. So I'm just going to, merge the first couple of questions. I think we have a question for Anvesha from Genevieve, and then also from Mo Hafiz. So it says, I was wondering if you could confirm your population size and whether you are planning to take an intersectional approach, interaction of sex versus ethnicity or sex versus social economic status. And then added onto that, if you would be looking at a range of ethnic spread, poverty, low paid workers being affected more than what better paid might have during the time covered.
Sure, thank you. So I'll take the first one. So the overall population, so far we've got, so those people who've had either a surgical aortic valve replacement or TAVI is around 200,000. of whom about 160 are surgical and about 40,000 are TAVI. And that's because TAVI has not been around as long as surgical AVR. So that's the overall population. And yes, so our initial plan is to look at descriptive data of what the spread is of all of those different characteristics first and how that impacts on the treatment received. But obviously, it'd be very interesting to look at the intersectional impact of more than one of those factors. So the initial plan is just to look at them separately, but then we would like discuss further analysis of how best to approach it, because obviously the data will be limited in terms of the ethnic spread is limited by the coding. So we know that it's not always the best description of people's characteristics, but we are limited by what the data is. So depending on what we find in the initial analysis, we'll then determine further analysis that we may do. I hope that answers the question.
Thanks, Anvesha. I'm going to defer, and we do have other questions in the chat, but I can see Genevieve's got her hand up. So do you want to respond to that just now, Genevieve?
Yeah, I just wanted to follow up. So 200,000 people will be your baseline, and then your numerator, your number of events. Do you have an idea of so
200,000 is the number of events. Our denominator will be, we're planning to use census data. So I want to look at the overall spread of the population as the denominator, and then off that, as a percentage, what the different groups who have the treatment, do they represent the overall population distribution?
Okay, yeah, I thought you were looking at whether people are going to get actual treatment once they've been referred.
Yeah, so we're looking at people who had treatment already. So we're looking at everybody who's already had treatment and spread of characteristics within that group and how representative that is of the overall population. And we're using the census data as our denominator for that.
Okay, thank you.
Oh, I can see someone is accidentally screen sharing, I think. So can I just ask, I'm not sure who that is, if we can just double check that you're not screen sharing. Thank you. I'll move on to the next question. Thanks, Anvesha. So looking at the next one, I think this is for Stephen. So we have two questions. So somebody's been looking for the reference or link to the Lancet publication. Just to note that Angela Wood has popped that in the chat, so the link is there. And also, Stephen, have you found that diabetic people have inherited long-term health conditions such as neurology, dermatology, or cardiology, noting that they've had several new health issues since the COVID era?
Interesting question. We haven't yet looked at that because we haven't had the data to look at. So it would be one thing to look at once we get into the theory. But obviously there's a lot of comorbidity in terms of diabetes, but whether that varies by age of diagnosis is also another question.
Thanks, Stephen. I have another couple of questions for you here following up. So the next one is, for the multi-state models, are you going to assume Markov?
Principally, yes, and we will use short time periods, initially maybe 1 year time periods, and then we will introduce tunnel states when necessary.
Brilliant. And another one for Stephen, sorry. So how will you define your study population? Will it be a fixed cohort that will be followed up, or will the cohort change across the years?
Yeah, ideally we would want to use time varying sort of cohort, so that's if feasible with the large data sets. So by time varying, I mean, you start the cohort in 1st of January 2020 with people who are alive, and then you keep updating their covariates, in particular diabetes status and age of diagnosis for people who develop incident diabetes. However, given the 60 million sort of records, it might be challenging to handle the whole cohort, but we might need to use subsampling and still do the same thing. Otherwise, we could use a fixed cohort at the mid-pandemic period.
Brilliant, thank you. So we've not got any other questions in the chat, but I'll just open to anybody who has any other questions. If there's any hands up at all, I can respond. Nope. No other questions. Okay, thank you very much to our speakers for today. I'm just going to ask Gemma to share a slide briefly. And if that's okay. Thanks, Gemma. It was really just to highlight through NHS Digi Trials that there is a recruitment service pilot opportunities. So there are 4 pilot recruitment slots available, and we just wanted to share that with the audience today if that's of interest to anyone that's attending today. There is a QR code that you can scan there on the screen. It is a very rapid call. It opened on the 3rd of October, and the first expression of interest is due by the 31st of October. So I'll just leave that slide up for a few minutes just in case anybody wants to take note of that. Anybody got any other questions? No, I think we're all done. So I guess all that remains today is to say thank you very much to our speakers for excellent presentations and for some really interesting questions. And if anybody has any questions at all come up or any other information that they would like, please do get in touch with us by email. And again, the webinar will be posted on the YouTube channel shortly at the HCR UK channel. Okay. Thank you very much, everyone. Thank you.